Hello and good evening, everybody. Thank you very much, for that wonderful introduction. And I'm thankful to Silver Star Diabetes for inviting me to an event that is chaired by the Right Honorable Mr. Keith Waz. It's indeed an honor, sir. Um, I know things still aren't under control with regard to COVID 19 there in the UK or even here in Kuwait. So please let's do our bit and let's continue to wear our masks, wash our hands, and maintain physical distancing. And let me take this opportunity to congratulate the Silver Star Diabetes team. You know, there's an obvious gap between what the diabetologist knows and what the patient must know regarding diabetes management. And I believe this communication gap can only be filled by diabetes patient education. This is one aspect of diabetes management that must be emphasized upon and promoted as much as possible. And so that's why what you're all doing at Silver Star Diabetes is commendable indeed. Now, I know we have people with diabetes today among our viewers, and I welcome every one of you. And I shall try to keep this conversation free of technical medical jargon. So, this is Kuwait, the place where I'm working at right now. I work at a specialized medical center where most of my patients are those with diabetes. Uh, Kuwait and the affluent Arabian Gulf countries have a problem. The prevalence of diabetes here is mind boggling. And let me tell you this straight up, most of it is due to diet and lifestyle, a high calorie diet and a sedentary lifestyle. Well, that's what a lot of money can buy, believe it or not. And in the next slide, you'll be seeing more of that, but in numbers. The graph in blue that you see on your left shows how prevalent diabetes is in Kuwait. And let me see if I can get the cursor to show you. That's Kuwait. And before that, that's Saudi Arabia. And before that, those are, you know, number one, two, three, four. Those are island nations or principalities. So, you know, if you're talking about nations, and this is where we begin, Saudi Arabia, Kuwait, Qatar, and so on. So you can see that diabetes is a huge problem here in the Middle East. It's about 23% here it's about 23% here in Kuwait, and in the UK it's 7%. So roughly a quarter of the population here already has diabetes. And this is higher than the United States as well, which you can see on the right side in the white box, in the white graph, where roughly 1 in 10 people have diabetes. Compare that to Kuwait, which is in the red, which is in the red bars, and you know that we have a problem. Those are alarming figures for us. The government here has acknowledged this problem, and government hospitals educate and treat people with diabetes. The state here provides all treatment for its citizens free of charge. Owing to the high prevalence here, the diabetes department is often the busiest. Kuwait also has the region's largest diabetes management and research center called the Dasman Diabetes Institute. It has on multiple occasions collaborated with British and American universities and hospitals to improve the practice of diabetes management. Apart from the native Arabs, we also have a sizable population of South Asians, Indians, Pakistanis, Bangladeshis, and diabetes is also highly prevalent among them. My topic today is the relevance of insulin, but I'd like to broaden it a bit to include types of diabetes, its complications, and finally, insulin use today with newer anti-diabetes medications. For many people with diabetes, insulin is a dreaded word. Well, I'm here to explain to you why it shouldn't be. First, let's acknowledge the fact that we are in the 100th year of insulin use. In fact, that anniversary was just 2 days back. On 11th of January 1922, a 14-year-old Canadian boy, Leonard Thompson, became the first ever recipient of insulin treatment as he lay dying at the Toronto General Hospital. You can see in the picture, that's the first ever vial of insulin used from the University of Toronto. Picture to the right shows a frail looking Leonard in the arms of his mother, and that was before he was treated. And the picture to the extreme right is that of Leonard after insulin treatment started for him. But you see, what this boy had was type 1 diabetes, whereas most of our viewers joining us today have type 2 diabetes. Well, what's the difference? Well, type 1 diabetes results from absolute insulin deficiency. Here, the pancreas do not and cannot make any insulin for daily living. And when insulin is not given to these patients, they develop something called diabetes ketoacidosis, where the accumulation of acid in the blood can make it incompatible for life. It usually starts suddenly, and patients are mostly young. And I've seen patients even to the age of 5 years, 4 years, that present with diabetic ketoacidosis, and that's the first presentation of type 1 diabetes for them. I've even seen people up to the age of 25 years presenting with diabetic ketoacidosis and type 1. Therefore, they were diagnosed with type 1 diabetes, and they're usually thin or of normal body habitus, and uh, the autoantibodies against insulin are usually present. And they can't make their own insulin, so that's the endogenous insulin is absent. And in type 2 diabetes, on the other hand, it's quite different. Here, believe it or not, there's no dearth of insulin. People with type 2 diabetes have what is called insulin resistance, and therefore a relative insulin deficiency, which is different from absolute insulin deficiency of type 1. The body doesn't utilize the insulin that is produced by the pancreas and cannot use glucose from the blood for energy. And to make up for it, the pancreas makes more insulin. There is insulin, but the body is resistant to it. That's why, to treat such patients with type 2 diabetes and insulin resistance, diet and exercise is also very, very important. So, most of the viewers joining us today who have diabetes will probably be type 2. So, to begin with, your physician may have started you on insulin sensitizer, a pill, most likely metformin or glucophage, and then there are a few more pills that with time are added to improve your blood glucose control. This is standard practice and it's good practice, but these days, with so much research into diabetes and its treatment, there are so many drugs available, one much better than the other. And with the advent of the so-called GLP-1 receptor agonists and SGLT2 inhibitors, again, pills and injections, both glycemic control and good cardiovascular outcomes can be achieved. So where does that leave insulin, the savior of people with diabetes since the past 100 years? Well, insulin has a role, and a big one at that, in diabetes. It is what comes to our rescue when patients develop complications from poor control of their diabetes. Complications, of course, are broadly of two types here: microvascular and macrovascular. When it affects the smaller blood vessels of the eye, the kidney, and the nerves, that's called microvascular complications. And when it affects the bigger or the larger blood vessels, like that of the heart, the brain, or the lower limb, and those are called the macrovascular complications. So when these complications So when these complications reach the larger vessels, it causes, like for example, to the heart, it causes an MI or a heart attack. When it affects the blood vessels of the brain, it causes a stroke. And if it affects the larger blood vessels of the lower limb, um, patients develop gangrene, diabetic foot, which may need to be amputated. The diabetes ward of a hospital caters to these patients with complications, which is when they present to the hospital. And in all those hospitalized patients, it's insulin that comes to the rescue when we need quick, effective, and efficient control of blood glucose. The whole point of diabetes management is to prevent complications. So, experts are now of the opinion that it would be best to introduce insulin earlier, especially for people with poor control of diabetes. And in my opinion, it works best if paired with another anti-diabetes medication. So, when shall we start insulin and what shall we pair it with? One could start insulin when your blood glucose is still very high, despite taking anti-diabetes treatment. And since it's actually a hormone, it can be paired with any of the drugs you're already on. Usually, it is paired with tablets such as Januvia or Invokana or the old metformin. But recently, with the advent of GLP-1 receptor agonists, those pens which I'm going to talk to you about, insulin is coming in fixed combination with these new drugs. You must have heard of liraglutide or Victoza. Well, Victoza has a more popularly known as Victoza. I hope the viewers can see this. So this is a typical pen. This is a Victoza pen. This is how it is. It's a pen, and you open it up, and you put a needle up there, and you twist this part, and you select how much the dose of Victoza you prescribed, and then you inject it as usual into the abdomen or into the thigh as you would for any insulin. Victoza has a more hefty brother, and it's called Saxenda, similarly. And these are both called non-insulin injectables. They work by something called the incretin effect. Well, it works very well in controlling blood glucose, especially after a meal, and it also reduces weight and improves cardiovascular outcome. In other words, it's good for your heart. A long-acting insulin like Lantus or Tresiba, for example, is paired with these new injectables. Paired as in they exist together, and it all comes in one pen as a fixed ratio combination. The presence of a long-acting or basal insulin would mean control of fasting blood glucose. So there are currently two of these combinations. You see them on screen, Zoltofy and Soliqua. And these pens, they work great for people with type 2 diabetes who are overweight and have high blood glucose readings throughout the day. Let me give you a real case example. A few months back, I was referred a patient. Now, Fahad is a 44-year-old obese, hypertensive patient. He has diabetes since the past 2 years. He weighs 100 kilograms and is 177 centimeters tall, which is about 5 feet 9 inches. His body mass index is 32. Anything above 30 is obese. And he was on metformin or glucophage and Amaryl or glimepiride. Of late, he has been complaining of increased frequency of urination, especially at night. And he also says he has tried to lose weight since his previous physician advised him to, but owing to his lifestyle, he couldn't. On lab investigation, he was found to have a fasting blood glucose of 22 millimoles and an HbA1c of 13.1%. So for those wondering about HbA1c, hemoglobin A1c, it is an average value of your blood glucose readings of the past 3 months, expressed as a percentage. In other words, it's your report card. To diagnose diabetes, we need a hemoglobin A1c of 6.5%. But as you can see in the odometer to the right, my patient's HbA1c, which was 13.1%, corresponds to an average blood glucose of 18. For a HbA1c like 13%, no tablet is going to help. This patient will need insulin, but he also has insulin resistance because he's obese. So our target is number one, blood glucose control, and number two, weight loss. And this is when the insulin GLP-1 receptor analog pens combination works very well. So I added this new pen called Soliqua. It's a combination of Lantus or glargine insulin with a GLP-1 receptor agonist called lixisenatide. We started with the minimal dose of 15 units and kept increasing every week by 5 units. So by the second week, he was at 20 units a day. I also intensified his glucophage. He was on 850 milligrams per day. I increased that to 2,000, and our educator and dietitian also counseled him about exercise and diet. But I think all the patients of diabetes must know that one needs to exercise for half hour daily, 5 times a week at least. Brisk walking works wonders. And Fahad did all this. We also gave him the Freestyle Libre sensor for blood glucose measurement, which he had a lot of fun with, and he'd measure his blood glucose multiple times daily. Now, just a word about the Freestyle Libre. As you can see in the picture, it's a sensor that you stick upon your arm and then use the glucometer provided uh, by gliding it over the sensor. It works even through cloth fabric, and you can connect it with your smartphone too. So, from the beginning of the third week of treatment, Fahad's blood glucose levels came down to normal. His time in range was 99%, meaning that 99% of the time his blood glucose was in range. And you can see that on the right of your screen. Keeping his diabetes under control was a priority for Fahad because both his parents are diabetic and his father had suffered an MI or a heart attack a few years back owing to poor diabetes control. His main concern was to try and prevent complications and to reclaim his life. So 3 months later, his blood glucose improved, as you can see. His fasting blood glucose is now 6.1, and his HbA1c or hemoglobin A1c fell to 8% from 13%. And he also lost about 4 kilograms of weight. So this is just one illustration of how insulin can be used timely and judiciously in people with diabetes. As we speak, there's a lot of research happening with regard to insulin. Earlier, we had only the rapid type of insulin. Now we have all kinds of insulin, especially the ultra rapid ones like the orange colored Novorapid pen, and so on. Humalog is another is another pen made by Eli, and so on. Um, Recently, a new type of insulin was announced that is sure to revolutionize the practice of diabetic medicine. It is still in the developmental stages. It's called insulin icodec and is a super long acting insulin that can be taken just once a week. This would be a boon for people with type 1 and type 2 diabetes alike. So you see, as we better understand the applications of insulin with all the new medications that we have at our disposal, and the fact that it is still the only potent medicine for diabetes that has time and again proven its efficacy, even in patients with diabetic complications, we realize that insulin is as relevant today as it was 100 years ago when it was first used. And patients with complications like diabetic foot, for them, it may be the only thing that saves their foot.